and a lot more esoteric is a word I love to use because it sounds smart, even though it's really not. Anyway, so you can't forget all that stuff and completely put it on the shelf. Like a lot of the stuff that we learned in the first block, especially the lab stuff, is going to come into play on this side as it should stand to reason. Because we're going to be talking about infections. We're going to be talking about prostate stuff. We're going to be talking about cancers on this side. So it's all going to play. So like, for example, if you guys remember, one of the things we're going to talk about today is pyelonephritis. Does anybody know some lab findings that go along with pyelonephritis? WBC-Cas, leukocytoesterase nitrite. WBC-Cas, leukocyte-Cas being pathognomonic for, right? So the reason I preface this with that is that if you see those and you're trying to differentiate between, is it cystitis, just a bladder infection? Is it pyelonephritis? If that's one of the things that you see, you already know which way to go, right? It makes it easier. So today's big lecture, today's big material is mostly going to focus on cystitis versus pyelonephritis. Very briefly, we'll talk about urethritis. But I will give you the bottom line right here up front, as plain as I can make it, all right? So, if you have, what is the bladder? What is the bladder? What does it do? What is its function? It is a bag of urine, right? It is a bag of urine that is made to containerize and hold urine. It has got a glycosaminoglycan layer that protects the inside of it so that it is not irritated by that caustic substance which is made by the kidneys that we call urine, right? So, it's all containerized, it all belongs there. If the bladder, or I should say the urine in the bladder, is infected, do you think that you would have any systemic symptoms, considering that it's containerized in the place where it's supposed to be? No, right? You wouldn't have any systemic symptoms, okay? You would have leukocytoesterase on UA, you would have bacteria on UA, you would have maybe some hematuria, you'd have nitrite, right? You expect those things because we're testing the urine itself. Would you expect to have fever? Would you expect to have leukocytosis? No, right? None of those things, right? Because if we have systemic symptoms, then we're thinking now that the infection has moved systemically. And what does that probably mean? Pyelo, which means that those bugs have been sitting, remember the static fluid lecture, right? If urine's not moving, static in the bladder. If it starts, those buggies start to creep up the ureters and make their way into the kidneys. Now we have an infection in the organ whose job it is to filter blood. And what does that manifest in? Systemic symptoms, leukocytosis, and fever. And what else with physical exam that you guys would check for? CVA tenderness, right? We're tapping on those infected kidneys. Really, if you can get that, the rest of it is easy, okay? So if you have a simple cystitis, you will not have a fever or any systemic symptoms, all right? What are the things they're going to have in common, probably? As far as like, let's talk about patient symptoms. Dysuria. Dysuria may be some urgency. You guys know urgency, the feeling that you have to go to the bathroom a lot. Okay? Dysuria meaning like that burning sensation when you go to the bathroom. Maybe hematuria, right? So maybe some darkening of the urine, if not, frankly, red urine, right? So there's commonalities, but there are clear-cut differences. And the reason why I highlight that again before we even start the lecture is because if you're reading a clinical question on a test, if you're seeing a patient in real life, if you're performing an osteo, all right, and you have these certain set of symptoms and signs and lab values, then you know this is pyelonephritis. If you don't have those things, this is just a simple cystitis, right? So the patient comes in, chief complaint, 28-year-old woman with dysuria for 3 days. You don't know anything else. Now, in your OSCE or your patient scenario or your clinical encounter with an actual patient, you look at their vital signs. Their vital signs are normal. Does that patient have pyelo? No. You see what I'm saying? It can just be that easy from the get-go. If that patient does have a fever, it's probably pyelo, but you have to do some more investigating because maybe they have two different things. But you see what I'm saying? If you say no to the fever, no dysuria, or no fever plus dysuria, it's a bladder infection. It's containerized, no constitutional symptom. Does that make sense to everybody? Because that really is the meat and potatoes of everything we're going to talk about today. So if you can get that, that's it. All right? Any questions about that stuff? All right. This is not rocket surgery, guys. This is urology. Urology is by no means easy, but this is a lot more hands-on. told you already, you're going to see this stuff day in and day out. If you don't see a UTI almost every single day in clinic, I will be surprised. If you ever see some of the stuff we talked about on the nephrology side, I will be surprised. You know what I mean? So this is day in, day out, bread and butter primary care. A little bit of terminology. Simple cystitis, like I talked about, it just means a cystitis, a simple bladder infection. You guys have heard it described as a bladder infection. That's what it is, right? It's an infection of the urine in the bladder. Uncomplicated versus complicated. Sometimes students get wrapped around the axle on this one, so let me just define. You see what uncomplicated cystitis is? Non-pregnant, pre-menopausal female. That is the patient who has an uncomplicated cystitis. If you are not that patient, then you have technically a complicated cystitis. So what does that mean? Postmenopausal females, pregnant females, and men. All right? Now, does that necessarily mean does complicated UTI mean pyelonephritis? No. Does everybody understand what I mean? It's just the patient demographic. That is how it's defined. This person is uncomplicated, everybody else is not. Okay? I said it wrong, but you know what I mean. I'm out of practice. I haven't been doing this. Anyway, so, but you get what I'm saying? Complicated, everybody else. Right? Everybody else. Urosepsis. Trying to think if you guys want to talk about that anywhere else, but essentially it's a sepsis that's originated in the urinary tract. Really, patients, you start to think about that, immobile, especially elderly patients, and kids, where you can't figure out where their infection is coming from. Those are the two that are really susceptible. The extremes of age or immobility are the ones that you really start to worry about urosepsis. And if you can't find a source of their fever, test their urine. That's where you commonly will find it. Okay? So, this is what we're going to go through. Why is a male patient a complicated UTI? Are UTIs more or less common in men? Significantly less common. And why? The simple anatomical length of the urethra. Literally, the bugs have a farther route to travel. All right? And so most of them, if not all of them, do not make it. They rarely make it. And that is why men rarely have UTIs. Now, not ever, but much less common. Okay? If you look at the length of the urethra versus a female urethra, it is a shorter distance to travel. Okay? There are periurethral flora that are protective, of course, but a lot of times women will suffer from UTIs post-intercourse because literally the mechanical rushing of the bacteria into the urethra, just the overwhelming sheer number will infect the urine and infect the bladder. Okay? Peeing is protective, right? The urethra is supposed to be an out pipe. Wash the bacteria out, right? Like I said, the glycosaminoglycan layer, so the urethra, all of the urothelium contiguous with the bladder and the distal part of the ureters covered with the glycosaminoglycan layer so that that urine is not irritative to that sensitive tissue, and it is sensitive tissue, right? And what is urine? Just big, waste, acidic, concentrated fluid. So if that layer breaks down, and we'll talk about this on the back half of today, the patient starts to experience pain. Okay? And then urine itself is not necessarily conducive to growth, right? Now, if it sits for a long enough period of time, if it is immobile, static, if the patient has an inability to void or inability to completely empty their bladder, then we have a different story. But in general, urine that's flowing and moving isn't really conducive to growing stuff. Okay? So, a lot of words here. We have, periurethral flora for women that are protective of foreign invaders, foreign bacteria, okay? And then we have the longer urethra, and they have some prostatic fluid secretions that contain zinc, which is slightly antimicrobial, but really what the natural defense mechanism down here is just, again, the anatomic length of the urethra. Okay? Now I have a little soapbox about the stuff down here on the bottom, right? You have to be comfortable asking your patient an uncomfortable, typically uncomfortable question, all right? You cannot be shy or demure when it's time to ask your patient about a sexual history, okay? Now again, a lot of you will be seeing patients that you are friends with because they're in your unit and you see them on a regular basis. You're gonna have to look at them in the eye and say, do you have sex with men? Do you have sex with women? Do you have sex with both? What type of intercourse do you participate in? Oral, anal, vaginal, or a combination? And why do I need to know that stuff? Because you need to know what route and source of infection might be present, right? It has nothing to do with an investigation really into their sexual behavior. It has to do with what might be the infective source for this patient, right? A male who participates in insert of anal intercourse, whether it's homosexual, heterosexual, or other, has a route for E. coli to travel through that urethra, right? So it makes more sense why they might have a urinary tract infection. Does that make sense to you? And the reason I say that is because people, students typically, especially as you're getting used to seeing clinical encounters, really kind of shy away from asking some of those questions because they are what you might call embarrassing or not a typical topic of conversation, right? But you know, when you go, I don't know if I told you guys this already, but I use the euphemism, like when you go to the mechanic, right, and you need an oil change, they're not like, I can't talk to you about oil, right? I need to talk about OIL. So I need to talk to you about SEX, right? Just, if it's weird to you, it's 1,000 times more weird to the patient. It should be like asking them if their knee hurts. You know why? Because it's our job, right? And if it's weird to us, it is so much weirder to them because then they're thinking, why is it weird? You know what I mean? So just ask the question because you need it. And we talk about it a lot over here because we do talk a lot about genital urinary infections in this course. Does that make sense to everybody? That's my little soapbox about that. So, urinary stasis, I told you, static fluid, no matter where it is in the body, is no good, doesn't belong. In the first half of the course, we talked about third spacing of fluid with the nephrotic syndrome, build up in the lungs, build up in the ascites, cause spontaneous bacterial peritonitis, pneumonia, so on and so forth. Here we're focused on that urine that's not really moving in the bladder, right? And so what is something on that a male patient would experience that might cause incomplete bladder emptying? BPH, prostatic enlargement, right? So that does become more and more common as your male patients get older and older. Then those urinary tract infections start to become a little bit more common because they have an obstruction, right? And the obstruction doesn't necessarily completely, obviously, cause them to be anuric, or it's a whole other situation. But what it does is it forces them to have to overwhelm that obstruction to urinate, and then they fatigue and they can't get all their urine out. So they are left with what's called a high post-void residual, right? Too much pee left in the bladder after they've urinated, right? After micturition, you should have 50 cc's, you should have not much of anything, maybe 5-10 cc's, left in your bladder. They have more and more, and as that more and more sits and becomes larger and larger and larger, as their obstruction becomes worse and worse and worse, then they are predisposed to a lot of these problems, okay? And let's see, what else on there? Incomplete bladder emptying. VUR, do you guys remember that one from the first block? Anybody? Vesicular-ureteral reflux, right? So we're talking about kids a lot there, but they have those incompetent physiologic sphincters at the ureter and bladder where they meet, and so you get reflux of that urine that goes north, right? And so you have kids with frequent urinary tract infections. And does anybody remember what the real risk of that is? Of that reflux? Hydronephrosis and hydrouria. Yeah, okay. Told you. Down here, less, neurologic conditions that should be fairly obvious, right? We might have patients who physiologically cannot contain or control their bladder anymore. So we might have patients that need to cath themselves, so on and so forth. Foreign bodies, diabetes, so they lost some of that micturition reflex if we were really poorly controlled diabetic, So, questions up to now? Pretty straightforward, right? So, as I was saying, and the reason why males have fewer UTIs, because it is an ascent of bacteria. Bacteria literally crawl from the outside to the end, crawl up the urethra, make their way into the bladder, see the urine, boom, urinary tract infection. Okay? There are lots of other ways that are potential, but these down here at the bottom, hematogenous or lymphatic spread, that's really, really uncommon 99.99% of your urinary tract infections are just going to be a simple ascent of the bacteria into the bladder, okay? And then, what this is saying, right? Most common route, this is cystitis, right? Cystitis. Now, if we have pyelonephritis, the little buggies have continued to crawl up the ureters into the kidney itself, right? So, I found that I say this a lot and it still doesn't stick for some reason. So I have a picture now of it as well, okay? That little crosshatch line right here, right? If the little critters haven't made it past the bladder, and you have cystitis. If they have crawled up into the kidneys, you have pyelonephritis. And if you have cystitis, right? If you have something down here, what kind of symptoms are you going to have? We're going to do this before we even get to the individual pathologies. We already did it. What's up? Dysuria. What else? Frequency. What else? Maybe some urgency. What else? We had dysuria, maybe some hematuria, darkening of the urine, right? Okay, now, the bugs have made their way north. Now, what are we adding to those symptoms? Fever, flank pain, CVA tenderness, right? And then systemic signs on labs. That's it, guys. I'm serious, okay? All right. I know it says plus or minus 85%. You can probably make that closer to 90. E. coli is going to almost always be the answer. All right, unless they're hospitalized, and then we're thinking maybe it's Pseudomonas, maybe it's staph, but it's still probably E. coli, frankly. Okay, so all right, now we're going to kind of go in a stepwise fashion. So right now we are at asymptomatic bacteria. Now, if I were to tell you that asymptomatic bacteria is not ironically named, what do you think the patient's symptoms are? None. And what do you think is in their urine? Bacteria. You guys are awesome. All right? Yeah. So, it may be counterintuitive. The reason we bring this up is because this bottom part here. You would think you find bacteria somewhere in the body, why would you not treat it? All right? And the fact is sometimes it will clear spontaneously. So, antimicrobial stewardship is sort of like been found through epidemiology that you don't need to treat this because more often than not in a healthy patient who doesn't have one of these conditions or is not one of these candidates, it'll either not cause any symptoms or it will spontaneously clear. All right. So you have a patient. They're not pregnant. And they are not about to undergo some sort of invasive urinary procedure, a cystoscopy, what have you, okay? They don't need any treatment. You just happen to, they have no symptoms, I'm fine. I just happen to find some bacteria in your urine. They don't need any treatment. Is that clear enough? Okay. Now, ACOG and AUA, so American College of Obstetrics and Gynecology and AUA, both agree that these two cases should be treated, all right, especially pregnancy. We're going to go to that next slide here, focus on that. Now, let me explain this one. Look at this bullet right here. If you have two, this is two lists in one, okay? So this is for a pregnant patient who either has asymptomatic bacteriuria or has a frank cystitis, simple cystitis, right? So whether the patient is completely asymptomatic and we just find bacteria in her urine, or she is pregnant and she has dysuria and a UTI, these are the same treatments, okay? Is that clear enough to everybody? All right. Now, I get this question a lot right here at this slide, and I'll answer it now. I don't usually ask dosage. I'm going to throw the usually away because then that's the only thing you guys focus on. I don't ask for dosage or duration, all right? Medicine is where I want the granularity to be, I know the right medicine to give to this patient, all right? Fair? Good. So, any patient who is pregnant can get any of these. Now there are some considerations, right? Like it says, Macrobid, which is going to be our first line in non-pregnant patients. You want to try to avoid that in the first trimester. You can use Septra technically, even though it's not on this list. But the reason to use either one of those is if there is a contraindication to everything else. So, what did I mean? Let's say this lady's in the first trimester of her pregnancy. She is allergic somehow to everything else. It is okay to use nitrofurantoin in the first trimester. That's what it means unless there's no other alternatives. Okay? But if you can, if she's not, then give her something else. Easy enough? Right. And yeah, you have some cross-reactivity with your cephalosporins and your penicillins, but usually it's not enough to be able to generate a real reaction. So she's going to have to be really allergic to go all the way down. Okay? Does that make sense, everybody? So again, just to reiterate, either this pregnant patient has no symptoms, but she has bacteria, or she has symptoms. This is what we're going to say in the same list. Okay? All right. Now, actual bladder infection. So this patient has the bacteria and they have the symptoms. Simple. Okay? Still, most likely E. coli. Most commonly a female patient, right? These patients oftentimes will experience frequent UTIs. A lot of times a female patient can tell you that she has a UTI, and she'll more often than not be correct. And so our job then just becomes, make sure it's not anything worse than that. Right? So, irritative voiding symptoms. You've heard me probably reference LUTS, LUTS before. So there's irritative and there are obstructive voiding symptoms. This one we're talking about more likely irritative symptoms. So they are literally things that are irritated, right? If it hurts when you pee, that's irritating. If you have to go to the bathroom all the time, that's irritating. If you have to get up at night to wake you up from sleep to go to the bathroom, that's irritating. So on and so forth, right? And let me draw your attention to the difference between frequency and urgency, right? So it sounds self-explanatory, but I've had students who kind of confound them, all right? Frequency means literally going to the bathroom all the time. Urgency means you got to go right now. I feel like I have to go to the bathroom right now. Or sometimes these patients feel like they may actually lose urine, okay? So. Gross hematuria. A lot of times what the patient might have is microscopic hematuria. They might have a little darkening of the urine. Frank red urine, I'm not going to say it's uncommon, but it's less common than the patient just complaining that their urine is dark and smelly. All right? And ask that question. It sounds like a silly question to ask. Does your urine smell particularly malodorous? Does it smell particularly bad? Right? So it doesn't typically have that urine ammonia smell. It might smell more gross than normal. Okay? And the patient will remark on that typically as well. And then here is the big one. Right? If they have a urinary tract infection, if it's just a bladder infection, cystitis, no systemic symptoms. See, look, there it is again, afebrile. Right? So you have that patient. Dysuria, hurts when I pee, times 2 days. Check the vital signs as the medic gives you the paper. They don't have a fever. You're pretty well assured that they don't have pyelonephritis, right? Almost never need any kind of imaging, right? If you have, the way where you would get to needing imaging, one is if you have somebody who has a frequent recurrent cystitis, they're getting bladder infections all the time, right? If you have a male who's getting urinary tract infections on a common basis, then it might warrant some imaging to see if there is some sort of obstructive or anatomic defect. But in general, like broad brushstroke here, patients who come to you with a UTI don't need anything as far as imaging is concerned, okay? These labs make sense, I hope. Okay. Pyuria, bacteriuria, hematuria generally, right? And leukocyte esterase and nitrite, both together, right? Urine cultures, remember? Don't necessarily assume it's a reflective test. Don't necessarily assume it's going to be ordered for you. Know your institution. and when in doubt, just order it, okay? Because you need urine and culture. Why do you need urine culture? Let me step back. How do we typically, like, if there was one word to say, how do we typically treat a urinary tract infection? Empirically, I think I heard it. Right? Empirically, right? We're going to guess that it's most likely going to be E. coli because it almost always is E. coli. What if it's not? And what if the drug we gave that covers E. coli doesn't cover the bug that it actually is, right? So even if you're 99.99% reassured that it is E. coli, which you usually will be, just still get the culture to make sure. Make sense? Right? So, all right, differential diagnosis, usually in the STI realm, urethritis realm, okay? Obviously, pyelo is still there as a reasonable differential diagnosis, but easy to eliminate. And then other things, I mean, really, cystitis is pretty obvious, right? Pretty obvious in its presentation. Complicated or uncomplicated, belabor this point a little bit just to remember there's this one patient demographic that fits the uncomplicated bill. Everybody else is technically complicated, all right? And usually what that does mean, frankly, you guys, is that we might treat them for a longer duration. You know how when you see prescriptions and they're given a spread, take this pill for 5 to 7 days, 10 to 14 days, something like that. Usually if we have a patient who doesn't fit the uncomplicated demographic, we tend to go to the longer end of that spectrum spread. Does that make sense, everybody? And I'll show you here in a minute when we get to the most likely drugs. Okay. All right. All right. So this is a big one. E. coli resistance rates are vastly different depending on where you go. All right. So, way back in the day, we would just throw fluoroquinolones at everything. And then you'd use Septra for a lot of things, but I can tell you here in San Antonio, Septra resistance, or E. coli resistance to Septra is up to upwards of 25%. So every fourth patient that you just empirically give Septra to is going to not resolve. So for that reason, BAMC's first line drug is macrobid, right? Nitrofurantoin. So just the reason for me telling you that is to make sure that you check your antibiogram when you get to wherever you're practicing so you know what to give, right? Just because it's macrobid here doesn't mean it's going to be macrobid in Fort Carson or in Fort Belvoir or so on and so forth, all right? So just check your local resistance rates because, again, you want to do what's best for this patient. Right? There's a couple, everybody, we always think about our patients who we can pull back in and grab, no problem, because in our unit. If you're treating somebody in an ER and they're family member or retiree or dependent or what have you, you might lose them to care, and then that simple cystitis that wasn't necessarily treated correctly because it didn't check the antibiotic resistance rate, then festers into pyelonephritis and becomes much more serious, all right? So just do the diligence and check and see what the right drugs for the right bugs are when you get to where you're going, okay? And then, like I said, we used to throw fluoroquinolones at everything, but risks outweigh the benefits on those, okay? So, except when we get to a certain patient demographic. In general, we used to just toss 750 Alerquin at pretty much any UTI, and now that's not good medicine, so don't do that, all right? So, this is what I meant. Like when you get to the only reason nitrofurantoin is circled here is because that's what we use here, right? But if you're talking about, say, a complicated patient, like a male patient with a cystitis, right? We're going to push these to probably 7 days, or we're going to go into the fluoroquinolones, something like that. So like a spread like this, if you said 5 to 7 days, if you get a complicated patient, we'll probably push them to the extra 2 days worth of care. Does that make sense? Just in general. Again, I guess I don't hold you guys to duration or dose. I just want you to know that in general. But some good ones, okay? Fosfomycin's good because it's 1 3-gram packet, right? Which means what? Yeah, you can give it to them and watch them take it. Okay? Does not have any renal penetration, so it is not indicated for pyelonephritis. Okay? You'll see some of these on the list when we get to pyelonephritis. Just understand that fosfomycin is not one of them. It has really good antibiotic efficacy, so it's a really good antibiotic, excuse me. So antimicrobial efficacy is what I meant to say. Nitrofurantoin, like I said, is really good. There are multiple different formulations, right? I don't know if you guys remember, but these are macro crystals, so it's the 100 milligram version. Not that you have to remember that for the test, but just understand there's a 50 milligram version out there, so if you don't pick the right one, you're going to be half dosing this patient, so pay attention. Right? And then really, these guys, we reserve more for our complicated patients, / somebody who might be allergic to everything besides fluoroquinolone somehow. You guys remember seeing these antibiograms, these susceptibility results? Right. This is a stupid one, but it's the only one I can get from ClinLab. But MRSA isn't used super common. I mean, obviously this is more than likely a nosocomial infection is something that this patient got in the hospital. But really, what are we looking for on an antibiogram on a susceptibility result here? An S, yeah, pretty much, right? So that we know, and then this is what we need. Like, this is why we need the culture. This is a culture result, essentially. So what we need is to make sure that the S is next to whatever we prescribe to this patient. Then we can be rest assured that they're going to be fine, okay? All right, any questions about the antibiotic care? Pretty straightforward, right? So don't forget, why is this patient here? Because it hurts when they pee. But don't discount your patient's pain, right? That'll get you dinged when you're documenting. Your patient is in pain, you don't do anything to address that pain, which giving antibiotics is not addressing their pain, okay? You'll get dinged on your notes in your peer reviews, all right? And just in general, it's good medicine. So, Motrin, Tylenol is fine, okay? Depending on what's going on with this patient. Can we give a Motrin even though it's nephrotoxic potentially? Yeah, why? Because it's not in their kidneys, this is in their bladder, right? See what I mean? So we can use them. And this, Ceridium, urinary tract analgesic, okay? Patient can buy it over the counter. Ask if they've already taken it. Obviously, in your good history of the patient encounter, you're going to be asking about over the counters. They can buy it, and so if they're not tracking, it's going to turn their urine that color. So you need to tell them that, or else they're in for an unpleasant surprise, and they will come back to you thinking that they now have gross hematuria. Okay, because when you're looking in the toilet and it's your urine, telling you the difference between orange and red is like spurious at best. So just tell them, expect this to happen, all right? But it coats the mucosa of the urethral of the genitourinary tract and helps relieve some of that irritation from that infected urine, all right? Complicated cystitis, as I said, don't tie me down to 7 to 14 days. Just understand when you're talking about care and it says blank to blank days, we're going to go for the longer spread in general for our complicated cystitis. And who are our complicated cystitis patients? Everyone who's not a premenopausal pregnant female. Exactly. All right? Okay, that's asymptomatic bacteria. That's a single episode of cystitis. Any questions? All right. So, recurrent cystitis. What does that mean? What does recurrent mean? It means it keeps coming back. It means it's documented, it's treated, it's resolved, and it comes back. Right? It's not an undertreated infection. It's one that keeps returning. Right? And those are two different things. So, just like I think you guys learned in ENT about tonsillitis and so on before tonsillectomy, those kind of things, documented 2 in a 6-month period or 3 in 12, right? So not that many to call it a recurrent cystitis, okay? Urology referral, I would make that referral, okay? And the reason is what you're gonna do for this patient is put them on a daily or a PRN dose of antibiotics. So I think the better part of valor here is to send your patient to urology to have them do an evaluation to make sure there's no anatomic defect. All right? And then, this one is huge. Okay? Telling your patients to increase their water. They should be making at least 2 liters of urine a day. After they have intercourse, they need to go to the bathroom to flush the bacteria out. Literally, that flushing of the bacteria helps reduce the burden of infection quite a bit. all right? If they're doing all those things, right, and it's still not working, then we can put them on 2 different dose regimens, right? Not both, one or the other, okay? So you can do a daily prophylaxis, means what? Every single day they take a low dose of antibiotic. And you notice they're pretty much the same antibiotics. So again, you don't have to rememorize the list. Or this one right here, the as needed postcoital. So after this patient has sex, take a pill. All right? Go to the bathroom, drink some water, take a pill. All right? And again, you don't need to memorize the dosages, but you can recognize they're the same. They're just low doses. Okay? So single strength, sector. 50 milligram versus 100 milligram. Okay. Does that make sense, everybody? So we have this patient with multiple documented infections. They don't have any kind of anatomic defect that we can take care of, like a bladder diverticulum or a stone that we weren't tracking. Put them on this, and then follow them up in 6 months or so and see how they're doing. And again, like when we talk on the urology side, especially when we talk about stones and infections, increase in daily dose of water works miracles if they will actually do it. Right? Thin out the mix, open the pathways, keep everything moving. All right. And then just remember, if you have cystitis in men, ask the good sexual history. Uncircumcised men technically have a slighter, higher increased risk, but still that's not an anatomical reason enough to explain away a UTI. So just do some further investigation, see if you can get to the bottom of what's going on. Okay. Any questions about cystitis? Okay. Good. All right. So pyelo. All the same stuff, but more. Okay. And like I said, the most common route of infection here is it just keeps going. We have infected urine, and the infection has continued to go north. Okay? Excuse me. So, I turned it back on and coughed into it, didn't I? You're welcome, everybody. Anyway, so fever, high fever, if you like that, I want you to tell Dr. Pine that's in here, just so she can come running in here protesting. Fever, higher fever. How about that? Okay? That's what it should say. Higher fever. Because there's either a fever or there's not a fever. But I mean severe symptoms. So what are we really moving into? Put this list together. What are we really moving into? Sepsis. Yeah, exactly. Okay? Sepsis. But everything here, systemic symptom, right? And then these are the same, right? These are the same for UTI, for simple UTI, bladder infection. Now, what are we adding? Why do we have white blood cell cast? Because we have an infection in the kidney. Infection in the kidney. Leukocytosis. Why do we have leukocytosis? Systemic reaction. Exactly. Right? Urine cultures, and then blood cultures are going to come into play here, depending on the patient. Right? Every person who walks in who has UTI, a little bit of a fever, does not need blood cultures. All right? It depends on the patient, depends on their comorbidity and their severity. Right? Does that make sense to everybody? Okay. CT scan, really we're going to talk about patients who have risk factors, diabetes, known chronic kidney disease, immunocompromised, maybe a pregnant patient, it has a CT but still imaging, right? So, or, this is the big one, patients who are not getting better even though our urine culture told us they should be getting better based on what we gave them, okay? So, this is what a pyelo kidney looks like if you're doing on a pyelo kidney, just angry, right? All lit up. Differential diagnosis, anything that can cause pain in this area. So all your peritoneal signs, okay? These patients are gonna differ from your chronic kidney, or not chronic kidney disease, your stone patients, right? What do stone patients usually look like when you see them? Like, what is their presentation? moving around, right? You can't get comfortable, right? But this patient has more of a peritoneal type presentation, right? They have infected kidneys, so they're sitting a little bit more still, all right? Even though they both have CVA tenderness. So just a little bit different. What this means is, if everyone's sitting in here, you get pyelonephritis, your kidneys are going to recover, no problem. The risk now increases for continued worsening chronic disease if you already have established kidney disease. Established renal disease, again, we talked about those acute on chronic illnesses, right? You're going to make, you have kidney disease, you're already at this level, right? You should be here for your GFR, you're already here. You get pyelo, you're going to dip, and you might not come back to your baseline. You're more likely to develop worsening of your chronic kidney disease if you get pyelo. Does that make sense? Diseased kidneys get disease, they're worse afterwards. It's all the same. Diabetics, you might see emphysematous pyelonephritis, so basically gas bubbles forming in their kidneys, which is one of the reasons we kind of lean towards that CT scan with them a little bit sooner. Now this, again, mostly your poorly controlled diabetics, not somebody who's on top of it, right? And usually not your type 1s who are really on top of it. This is somebody who's really pretty poorly controlled and immunocompromised, and usually already pretty sick. Does that make sense? Okay. Do we have to put everybody who has a kidney infection in the hospital and keep them with us? No, we don't. Not by a long shot, all right? In fact, I'd say most of your patients that you would see will probably be able to go home, but we have to have a couple of things that we're assured about. One, that they're a compliant patient with their medication regimen, and two, that you are reasonably assured they're going to follow up with you, okay? Which is to say very assured they're going to follow up with you. Because we can't let this go and let this patient be lost to treatment. We have to be sure that we're going to be able to re-evaluate them and see if they're getting better, okay? Because again, if they get worse, where does worse go to from here? It goes to sepsis, you know what I mean? All right? It's not something that you really just spontaneously resolve. Now, take a look at this. A lot of stuff on this slide. Holy. Anyway, so if, like, you're seeing a patient and you're seeing an outpatient urgent care emergency room, if you don't know what the local E. coli resistance is, or if you know that it's greater than 10%, their first dose in clinic with you is going to be an IM, right? You're going to give them a shot of something. Usually that shot is going to be Rocephin. Okay? And then in this case, now, worse infection, bigger gun, we're going to use our fluoroquinolones. Does that make sense to everybody? All right? So, in a simple cystitis, our risk-benefit is like this. Too much risk, too little benefit. In our pyelonephritis, when our kidneys are infected, benefit way far outweighs the risk, okay? Make sense? So, notice the plus here. We're going to give this patient a shot in clinic, in the emergency room, in the urgent care center, and we're going to send them home with this medicine to take for the next 5 to 7 days. But we want to see them within 72 hours to reevaluate. You don't need to know this one. Okay, so everybody just cross this out. The reason I put this up here is because if they are allergic to fluoroquinolones, now again, I told you might see some of these. The list should look similarly familiar, or kind of familiar, list to list to list. They're very similar drugs that kill our uropathogens. But you don't have to worry about this one. All right, I'm not going to ask you if the patient's allergic. If the patient's allergic to fluoroquinolones, look it up. Okay? Right. And then, who do we need to keep with us? Is there anything on this list that's like, why would we keep that person in the hospital? No, right? Uncontrolled symptoms, pregnant, diabetic, comorbid, chronic kidney disease. Just your clinical gestalt says, I don't want to send this patient home, all right? So that's the only point of this slide, is that if we have something that makes this patient significantly higher risk, we're just going to hold on. All right? And then inpatient management, don't worry about that, all right? Don't worry about inpatient management regimens yet. But the point is, if you look, it's going to be probably an IV fluoroquinolone that we're going to have that patient on with pain control, making sure their fluids and their ins and outs are monitored. And then, when they are getting better, clinical resolution. What do we talk about clinical resolution? What do you think? Their fever starts to get better, right? They start to feel better. All right? 48 hours, we can switch to the PO therapy. At that point, probably send them home. All right? Now, this is the big one. If we have urinary cultures, urine cultures that say the medicine that we gave this patient should be treating this bug, but they are not getting better, then we need to get a CT scan for that patient, because there might be an abscess form, which could be bad. Abscesses in your kidneys are bad. Write that down. And then the other big one here is, didn't talk about this really with cystitis. It's not really that necessary, right? But we have a patient who had an infection of the renal parenchyma. Bring them back in, culture their urine, make sure it went away. Okay? Make sure it's clear. All right, questions? All right, real quick, because I'm sure you talked about urethritis in ID, I imagine. Maybe? Okay. Well, we'll talk about it real fast. The reason I bring it up, obviously, is because it's part of the genitourinary tract. Most of what you guys are going to be seeing will be gonorrhea and chlamydia. Those are really what we're concerned about, right? And did you guys talk about mycoplasma or ureaplasma at all in ID? Those bugs sound familiar at all? So mycoplasma is becoming a pretty big culprit in non-gonococcal urethritis. It presents very similarly to chlamydia, so sort of insidious symptoms with dysuria, but it's becoming a more common uropathogen. Fortunately, though, they make PCRs now that you can order that will rule out gonorrhea, chlamydia, mycoplasma, ureaplasma, and trips. You can order one urine test that will cover all of those for you. And even if you didn't, if the patient has mycoplasma infection and it looks, it kind of looks and presents like chlamydia, and you're going to treat it empirically like chlamydia, the chlamydia treatment will treat that as well. Just understand they are two different bugs, all right? Which means that antimicrobial resistance may start to develop in the chlamydia or the mycoplasma, and then they might split treatment pathways. So just understand there are more bugs than just GC out there causing those kind of symptoms, okay? We have to go over gonorrhea and chlamydia. You guys know this one? Yeah? Remember, this is the big one I always go, this is the big soapbox on this one. If the patient's exposed to one STI, what does that mean? They're exposed to all STIs, so don't forget an STI panel, okay? So RPR, syphilis, right? Hepatitis panel, acute chronic hepatitis panel, HIV. Herpes swab, if lesions are present, because herpes serology is garbage, all right? And don't forget sexual history, because the urethra isn't the only place that STIs take hold, all right? They might need a rectal swab, they might need an oropharyngeal swab. You won't know that unless you ask a good pertinent sexual history, okay? Let's see. We'll get rid of that. And then treatment for GC and mycoplasma, like I said, it covers. So, if you have the results and you know that it's just gonorrhea, not chlamydia, then you don't have to treat for both. If you're empirically treated, you need to treat for gonorrhea and chlamydia if you suspect gonorrhea, because the symptoms of chlamydia will be masked by the discharge of gonorrhea, okay? And don't forget this kind of stuff. New students especially always forget patient education. They need to abstain from sex. You need to try to do contact tracing if you can. Get them to your public health nurse, who typically will work in your clinic, because the gonorrhea, chlamydia, these STIs are reportable diseases, And so just make sure appropriately, one, you're giving them the education not to spread it around, and two, if their partners potentially have symptoms, that they should seek treatment as well, okay? I'm gonna do the next one too, because it's only 21 slides, we're gonna go through it real fast, all right? You guys wanna take a break? Yep, go for it.